Okay, welcome back everybody for this last part of Science in the Age of Experience 2023. I hope you enjoy the break and our charge up to deep dive into the last final session of this conference. We've seen life sciences, industries, planet, nutrition, food science, so you can tell that Dassault Systèmes is very serious when it comes about science. As you know, our conference will be followed this afternoon and tomorrow by our annual symposium on virtual twin of human experiences dedicated to healthcare, life science, and medical practices. And it's already the largest event on this topic in the world. So to transition to that next phase of the Science Week, we would like to finish with healthcare, and more precisely, cardiovascular and heart care. The depth of our knowledge with programs like the Virtual Heart, Living Heart, has increased radically in the past few years. In terms of surgery, what was unimaginable just a short while ago has become reality. A big game changer is being able to test procedures digitally with virtual twins before you do them for real. This is an incredible step forward. We are honored to have with us two renowned cardiologists and practitioners, both leading groundbreaking work in their specialties. First, Pierre, professor at the University of Bordeaux, where he managed the Electrophysiology and Heart Modeling Institute. He works on improving knowledge and treatments of electrical dysfunctions of the heart. Second, Dr. Alain Zahiaras, professor of medicine, section head of structural heart disease, co-director of the Center of Valvular Heart Disease at Washington University School of Medicine, St. Louis, Missouri. He's an interventional cardiologist, widely recognized for his contribution, especially in advanced treatment of heart valve disease. And Dr. Zahiaras works with Dassault Systèmes, Life Science, and Simulia on modeling and simulation. We will start with Dr. Pierre. Pierre, are you with us?
Absolutely. Hi, Patrick.
Hello, Pierre. I'm so happy that you join us remotely live. I can testify and tell me what you think. Saving lives, like what you do, is a 24-hour mission. Because, I don't know, it's 5 a.m. in France right now?
5 p.m. in fact.
5 p.m. Okay, so it's still a 24-hour mission, but but I'm very happy that you're with us today. So we will let's welcome you warmly and give you the hand and the floor to show you what you do with mod, sim, data science, and medical practice for heart. Thank you very much.
Good morning, everyone. Thank you so much, Patrick. It's a real pleasure to participate in that major event. I only regret I couldn't make it in Boston and be with you. The program looks absolutely outstanding. So I'm going to present on the power of digital twins in cardiac arrhythmias management. Please note that I have this conflict to disclose here. I'm co-founder of InHeart, and you will understand why this is relevant to that presentation, because you will see many InHeart slides. The first thing I'd like to say is that when we started working on that digital twin, we did not really anticipate that it could be used for so many applications. And we started with ventricular arrhythmias, and I'm going to have the first third of my presentation based on that. And then it evolved to some risk assessment for sudden cardiac death, atrial fibrillation, but it will play a role in heart failure, I'm sure, and definitely in cardioembolic stroke. And I'm going to show you some, few slides at the end of my presentation on that topic. So, how do we proceed when we treat patients with ventricular arrhythmias at the present time? Well, first of all, this is the electrocardiogram, which is the electrical activity that you can record from the surface of the thorax in a patient in normal sinus rhythm. It's pretty slow. It's 60 beats per minute. And in sharp contrast, this is a ventricular tachycardia, and this is another one. So it's a very fast rhythm. It's above 100 beats per minute, but typically it is ranging from 150 to 300 beats per minute. And as you can imagine, 300 beats per minute, you don't survive that for very long. If nothing happens, you may die out of it, and pretty quickly. So when it happens, patients are referred for what we call a catheter ablation of this arrhythmia, which is the only way to really suppress the arrhythmia and cure it in a way. And so this means we are using this kind of diagnostic catheter with plenty of electrodes, these tiny, shiny rings here on the splines of the catheter. And we go everywhere in the ventricle, in this case, the left ventricle. This is a patient with a previous myocardial infarction in the inferior and septal aspect. And you see here that with a color-coded activation map, we can follow the circuit in this area here that has been contoured with the black dots is the area that is critical to the arrhythmia. It's in the myocardial infarction scar. And this is a nice process. It takes a little bit of time, like 20, 30 minutes, and it suffers several limitations. For example, in this patient, we had 9 different morphologies. You can imagine that reproducing this mapping strategy for 9 different ventricular tachycardia is really unpractical and would translate into a possibly 7 or 8 hours procedure. So very unpractical. It's very difficult for the patient to have that many arrhythmia mapped, and it is, in fact, not possible in most cases because it would be very poorly tolerated. So the tolerance of the arrhythmia is a major limiting factor with this strategy where we induce the arrhythmia. And the blood pressure, typically, if we would start at 12, after a few minutes, it drops to 5 or 4 or 3, and we have to terminate the arrhythmia without having a complete map even done. So that was one of the reasons why we started looking into imaging. Another reason is that imaging is a very, very good thing to do in patients with structural heart disease to better understand what is going on. This is a series of almost 160 patients in whom we've been looking at the diagnosis before MRI, before imaging, and after MRI. And the take-home message here is that if you just do an echocardiography and angiography to your patient, well, more than 50% of the time, you have no precise diagnosis for your patient. If you use MRI, this drops to 1/3. So there is a real benefit. But beyond that, MRI, as shown here on the right, can describe the scar very nicely. This image, in fact, is a combination of a CT scan, because there is no way you can get these anatomical details with an MRI. The spatial resolution is not good enough yet. So, but it describes the scar very nicely with late gadolinium enhancement, which is this blue thing here. And we can, classify the scar according to whether it appears very dense on the MRI or intermediate, which we call gray zone. And then we discovered that CT scan, in fact, was doing a very good job as well in describing scars. In describing the anatomy, it's even superior because superior spatial resolution. But describing the scar with late iodine contrast works pretty well with CT scan. It also shows you where there is a fatty infiltration, a fatty metaplasia in the scar. This is the green aspect here. And there's more you can do with a CT scan, which is looking at the wall thickness. Sorry. So you're taking advantage of this spatial resolution. And in dark red here, you have an area of the scar that is really thin, like 1 millimeter or less. And then immediately you see that the scar is very heterogeneous. You have a big dense scar here, another big dense scar here, and in the middle you have something where the wall thickness is preserved. Well, this is super interesting information. We had no idea before we did some CT scan for those patients, but it's very, very interesting. And there is a lot you can tell with our historical approach where you take a catheter and put it in the heart of the patient. But when you have your electrodes facing this complex area where you have in white here some scarring that is intramural, meaning that it's sandwiched by two areas of normal myocardium that appear in black here on the external aspect and here on the internal aspect, well, then your electrical information will tell you this is normal myocardium, which is not. So if you want to have an idea of what is happening in the depth of the muscle, you need imaging. Now, when we have those patients with ventricular arrhythmias, the conventional approach, again, consists in mapping. This is an example of a map. You can see that the anatomy is kind of approximative. And this is the X-ray image we get with our catheters. And this is the echo image we sometimes use. And this is a schematic showing you the ablation catheter burning in the left ventricle, some area that is critical to the arrhythmia. And it takes 4 or 5 hours to understand where the arrhythmia stands. And then the therapy itself is less than 1 hour. So what we figure out is that it's possible by using these imaging that are done anyway before ablation to, excuse me, to reconstruct in 3D the heart of the patient. We call it our digital twin. It has different pipelines according to the different conditions we are exploring, and it gives you a super detailed anatomy of the heart of the patient. This is the aorta in red, in blue is the pulmonary artery, green is the phrenic nerve. You don't want to destroy the phrenic nerve during the ablation, which is burning the tissue. These are the coronary arteries. You have to respect them as well. And here, color-coded is the scar from myocardial infarction in this case. This is another case, and it shows you that you can move your cutting plane and see what the reference CT scan image is. And this is another case where you see how heterogeneous the arrhythmia, the substrates may appear, and you can design your therapy plan before getting to the lab. You can discuss that with your colleagues. You can agree on a treatment plan. You can even explain to the patient before the ablation procedure what is going to be done on his heart and on his scar to take care of his arrhythmia. And so this is a short video showing you one of these patients, very challenging patient. Please stop the video here if possible. We have contoured in white the very dense scar where the wall thickness is 1 millimeter or less. This is it here. And so you see it's a very large myocardial infarction. And in between those areas that are acting as inactive during the ablation, we can see the isthmuses. So what you're seeing now is the ablation itself. So we are sorry, you did not stop the video. So anyway, you've seen the ablation of this arrhythmia, which was difficult in this patient because he was continuously in arrhythmia, which was very poorly tolerated with a blood pressure of 3 to 4 millimeters of mercury. Thank you so much for getting back to that. So you can restart here. So you see it's very fast at the beginning. On the top of the tracing, you have the very fast ventricular rate. And we started by the most active isthmus that we identified with the imaging. So we take our ablation catheter and straight go to the point and ablate where the arrhythmia is coming from. And because of that, we are skipping some very difficult strategy and very costly strategies where we should use a external pump to pump the blood while the patient is in arrhythmia. So it's very advantageous to use this digital twin. And you see now the situation is much better. The patient is mostly in sinus rhythm, few bits of arrhythmia, but mostly sinus rhythm. So it's the procedure is not completed, but we took care of the most active isthmus, and the procedure was completed by ablating all the channels we have identified by imaging. But again, the diagnostic phase is no longer done during the procedure. It's done before with the imaging, and then we straight get our catheter in the heart of the patient, and we navigate that catheter in the space directly to the area that matters and that need to be treated. So this approach has been largely validated with over 50 publications in peer-reviewed journals, and we validated the acquisition of the images, the pipelines we have created to process them, and the ablation strategy that relies on the ablation itself is currently being investigated. But this demonstration that imaging is important has been made very clear now, and it's included in the 2019 international guidelines. So we're very proud of that. A form of validation is shown here. So you have on the right, if you can start, thank you, start the video. You have on the right, again, this map that is showing you the circuit of the ventricular tachycardia with this isthmus here in the scar. Well, that's exactly what we have on the image by the CT scan in this patient, and we have largely demonstrated this very good match. I told you that we were validating this approach. In our experience, it's 60% faster when we use the digital twin to guide the ablation procedure. It takes very consistently 2 hours versus 5 in the past. And it's 25% more effective as we have fewer redo procedures that are needed. There is an ongoing multi-center randomized control trial to demonstrate that superiority, and a health economic study that goes with it. And in the future, in my opinion, we are going to use this type of ablation catheter. We call them big footprint because they are a centimeter diameter versus 2.5 millimeters for those who are used currently at present time. If you take this catheter straight to the isthmuses that have been identified by imaging, then the ablation procedure is going to be super fast because you save time on the diagnostic phase, which is with imaging before the procedure. And then the ablation part of it is going to be faster and more effective because in one spot, you can kill one isthmus. You don't have to do point-by-point lesion. So it's going to be way superior. And it will make, in my opinion, ventricular tachycardia ablation a 1-hour procedure, which means that we will have more and more patients that can benefit out of that. Now, because we have built our digital twin on the MedInRIA platform that has been developed by INRIA in France, and Dassault knows INRIA very well. They're working with them as well. We can do simulations, and this is something super exciting. So this is the map we got in the patient heart. So we mapped this arrhythmia with some catheters, and this is what we have in silico, in the computer. I'll show you a little more how we do that, but basically it translates the wall thickness into conduction velocity, and we can also simulate the 12-lead electrocardiogram. So very exciting future with simulation. It takes advantage of some aspects of the previous work I presented. So the segmentation, LV wall thickness segment computation, it's already there. And then we have developed with Maxime Sermezan and Nicolas Sedelnik this model where, again, the thickness translates into conduction and into action potential duration. It's a little bit technical, but it means that we can run some very extensive in silico stimulation protocols that are super useful to better understand the substrate of the patient and how the arrhythmia behaves. And so I'll take you to the next slide, where we did run that in silico test. Could you start the video, please? It looks like it doesn't start it by itself. And so you're going to see, here it is. So this is slow stimulation, and then it induces the arrhythmia that you can see here in the computer model, which match perfectly what you see on the left, which is what was recorded in the patient, so the reality. This is another example. Could you please run it as well? Where here we are pacing, and again with some extra stimulus, which is the usual protocol. We have this rotational activity in the scar that mimics perfectly what we recorded in the patient, and that is shown on the left. So I'll move to next. And I'll briefly present on risk stratification, because I think this is going to be a major achievement of digital twins in cardiology. We're going to use both imaging and electrical information to try to do a better job at predicting who is at risk for sudden cardiac death risk because of ventricular arrhythmias. So it's a major cause of death in the world, sudden cardiac death. It's in Europe, it's 350,000 deaths every year. It's massive, and it's only increasing. Not all of them are coming from the heart, but it's a significant percentage. And the good thing is that we can prevent that sudden cardiac death from happening by implanting a cardioverter defibrillator. It's a machine that will send a shock automatically if a fast ventricular arrhythmia is detected. The problem is that at present time, the criterion to decide the implantation are very limited and result in a poor outcome. So 60% of the patients implanted will never use their ICD. These cardioverter defibrillators, they cost 25,000 euros a single unit. So it's massive cost, and more than half of the patients implanted are not using it. It's a total waste. And on the other hand, more than 80% of the patients who are going to to die suddenly are missed by that screening strategy. So it's a very difficult situation for us as doctors. Now, the good thing is that imaging is very helpful here as well. And digital twins will in the future do a very good job at giving us the opportunity to better identify patients at risk. So here, this is late guard enhancement. This is MRI, quantifying the scar in the muscle, in the cardiac muscle. If it's absent, you have a much better prognosis as compared to 15% of the mass of the left ventricle occupied by a scar. So it's already an international recommendation to use imaging to quantify the risk for those patients. And we have developed tools, and they are almost ready to do that quantification automatically. And this is very important because it has to be homogeneous and it has to be the same in every center in the world. It's going to happen for non-ischemic cardiomyopathy as well. We have a large series, over 1,000 patients here, that are demonstrating that this quantification of the scar is already superior to the ejection fraction, which is the gold standard at present time. Same thing for ischemic cardiomyopathy, where again, the quantification of the scar is superior to the ejection fraction, again, the gold standard. But there is more than just the quantification of the scar. And it's absolutely fascinating to, work outside silos and get our field tightly connected to the field of imaging, because it means that we will benefit from each improvement. So this is black blood lead gadolinium enhancement MRI. It's a new acquisition modality that we have developed in the Lyric Center, my research institute. Photon counting is also amazing. I'm going to explain you why in the next slide. This is so in the middle, superior row in the middle, you have the CT pixels that is 600 microns, 0.6 millimeters. It is better than MRI, which is on the right, and which has a spatial resolution of 1 to 3 millimeters. But in the lower part of the slide, you have this yellow grid, which shows you the pixels by the photon counting CT scanner. It's 100 microns. It's amazing jump and improvement in spatial resolution. And in addition to that, you can quantify the energy of those photons, and this translates into a kind of tissue composition analysis that you can refine with multiple contrast agents. So we're going to have a completely new way to explore the heart, and those 30% of patients that remain unlabeled despite having some cardiac arrhythmias. I think that with this modality, we're going to have some diagnosis for them. So it's really important and exciting. And this is now up and running in Bordeaux. Only a week old. So that's the very beginning, but we are super excited. Now, a few more words on simulation, because I think this is also going to help us to better define the risk. The concept being that in the in silico model, you can run as many tests as you want. And this is what we have started doing. This is on the right, the video. And you can probably refine the risk by defining whether if you try 100 sites in the left ventricle, you have only one that induces VT. It's probably a fairly low risk, even lower if it's zero. But if it's 50% of the sites, it's probably meaningful and something we will look at. Now, there's more, and we have already explored some other AI-based arrhythmia risk prediction that is shown here. This is the left ventricular ejection fraction performance in terms of accuracy. So it's the lower left table. The lower row is showing you the LVEF. So that's the gold standard way to assess the risk for a given patient to have or not ventricular arrhythmias and sudden cardiac death. You see the numbers, so accuracy is 0.671. And if you look at scar age, it's doing better. If you look at scar size, it's doing even better. And deep learning is superior to all of these criteria. Why is that? Well, because deep learning learns not just the extension of the scar, but also the heterogeneity and the presence of isthmuses. And so it learns the risk in a much more accurate way. And you see, this is preliminary work, but still we trained on over 400 patients and we tested in 150. So the last two slides are on something I'm very excited about, where the cardiac twin of the heart that we are developing can help in predicting the risk for cardioembolic strokes. So Strokes are terrible events that leave you paralyzed or that kills. We have in France over 250,000 strokes every year. These are numbers from 15 years ago, so it only increased in the meantime. And the cost is huge. We're talking about billion euros. And at least 20% of them, more likely close to 30%, are coming from the heart. So we want to be able to predict that risk in a much better way than what we do at the present time. It's a bit technical, but at present time, the only entry point to the assessment is atrial fibrillation. But some patients without atrial fibrillation will also have strokes. So we want to change the paradigm here and take advantage of this preliminary study where we use artificial intelligence to explore the shape of the left atrium and particularly of the left atrial appendage here on the superior left corner of the slide, and also of the pulmonary veins. And we did that in 500 patients, and that graph was able to sort out, it's the yellow tags versus the purple tags, was able to predict which patients will develop a thrombus in their left atrium. And this is the source for cardioembolic strokes. So we do believe that we can use that to predict the risk much better than what is done at present time, which is very primitive. We do believe that we can extend that knowledge from injected with contrast agent CT scans to non-injected CT scans, and that we can combine it with the surface ECG to have a very refined prediction. And this tool will then be, deployed in the hospital clinic, and will screen on a daily basis every test like CT scan or surface ECG that is done, and will send alert messages to doctors saying there might be an increased risk here. You may want to consider other tests, or you may want to consider an anticoagulant treatment, which is the only treatment that works to prevent those strokes from happening. Thank you so much for your attention.
Thank you, Pierre. Thank you, Pierre, and thank you for making the remote presentation. Just one quick question, because this was very deep and wide. Since you are basically changing the practices and the standard aperture, do you think that in terms of medical act, you will need to have new coded act with twins?
Absolutely. This is crystal clear to me, and it will be our responsibility to conduct large studies, also demonstrating the economics and the cost efficiency of this strategy, which I'm sure will save a lot of money, because strokes, for example, or sudden cardiac death cost a lot. So it will be our duty to demonstrate that it's in fact helping healthcare systems and patients, and then it will be obviously reimbursed.
Thank you very much, Pierre. Thank you for showing us the future of medical acts based on twins.